I'm Donna Gress, and the topic today is lung cancer, AJCC 8th edition staging. First, we're going to talk about the T, N, and M categories. It's important to understand the lung anatomy to get the tumor location correct. There's many different structures in the lungs, including the carina, the main bronchi, the lobar bronchi, bronchioles, lobe locations, lobe fissures, hilum, mediastinum, the apex, medial and lateral positions, and pleural-based, which means it is near the pleura in the periphery of the lung. It's really important for registrars to have access to good anatomy courses. It's important to improve our skills by reviewing different material available, maybe even taking some online courses or invest in anatomy books. Many different issues that come up with lung cancer staging are really based on knowing and understanding the anatomy. Another important part is the role that diagnostic procedures play in staging. Knowing what can be visualized by endoscopy procedures such as bronchoscopies and mediastinoscopy. Also, what can be seen during a thoracotomy or a mediastinotomy. There's, again, a lot of online information or books available that can really help the registrar with this. Now, the hilum and the mediastinum. The anatomic definitions are that the hilum is the location where the bronchi and the blood vessels enter the lung. The mediastinum contains the heart, the trachea, the esophagus, and the great vessels. Hilar or mediastinal may also refer to lymph nodes. So when you see these terms, it could be talking about lymph nodes or the anatomic area. Here are some examples from Cancer Forum. A right hilar mass FNA. Patient had a right lower lobe lobectomy. So the hilar mass must be lymph nodes, since the right lower lobe of the lung is not near the hilum. So that's not where the primary tumor was. A large cavitary mass in the right upper lobe extends into the right hilum. You really need further information whether this is extending into the hilum or it's talking about hilar nodes. Now, the right upper lobe mass, mediastinal adenopathy, and then an FNA of the subcarinal node is negative. So this is probably telling you that it's not the anatomic area, but it's really talking about mediastinal nodes, and they are not involved since the biopsy was negative. A 6-centimeter mediastinal mass involving pulmonary arteries, chest wall, and rib. This is talking about the anatomic area of the mediastinum, but it could also include nodes that are in this mediastinal area. So you can see how it can be very confusing, and many times you need to read further into the notes in order to determine if they're talking about lymph nodes or the anatomic area. Now, the clinical T category. It is critical to read the main and the subcategories when you're trying to assign the correct T category. There are times that the information to assign the subcategory may reside in the main category. For example, there are T2A instructions within the main T2 category. It's also important to review all categories. Sometimes a tumor may meet the size of a T2, but have an invasion of structures listed in T3. There are many different criteria involved, including both size and invasion. You must select the category that reflects the worst criteria. So you have to be very careful. And a lot of times I'll talk to registrars about kind of playing a game of that's too much. So keep reading all the criteria until you finally get to a T category criteria that's too much. You don't have any of those structures involved. Then you know that you've read through far enough, because otherwise you could very easily assign a lower category that's not appropriate. It's critical to understand the anatomic and the disease terms that are being used in the medical record. There are many different anatomical structures, and they play a role in assigning the T category. And then there's also disease terms such as atelectasis. And it's important to know what those terms mean so that when you read them in the chart, you understand and can apply that criteria correctly. Now, lung is unique that TX has two different criteria. This does not happen in any other disease site. So one criteria is TX can be microscopic findings without a visible tumor. And this would be as if you found tumor cells in the sputum cells or the bronchial washings. But when they did examination of the lung, no one could find a visible tumor. So this would be assigned TX N0M0 for an occult carcinoma stage. Now, the other definition is the one we're all familiar with. TX is tumor that cannot be assessed. The physician may use TX not assessed with an N1 through N3 or M1. With N0, M0, there is no tumor found, and it isn't a cancer case, not with this type of TX definition. So it's critical for registrars to make sure they're using T blank or skipping that T data item for lack of information and not assigning TX, particularly in this situation where TX has these two different meanings. The physicians could misinterpret the registry lack of information as actually being an occult tumor in the lung. Clinical T and pathological T categories. Multiple tumors are not always separate tumor nodules. Separate tumor nodules has a very important definition. It is considered intrapulmonary spread from the primary lesion. This affects the assignment of the T category or even the M category. T3 is separate tumor nodules in the same lobe. T4 is separate tumor nodules in different ipsilateral lobes, and M1A is a separate tumor nodules in a contralateral lobe. Now, some histologies have multiple synchronous tumors as part of just the way they act. So that you would assign the T category, but the largest tumor size, and use the parentheses M for the T category suffix. You must use that parentheses M to indicate the tumor burden for that patient, which is different from a patient who only has one tumor. This does not affect the assignment of the T category. Pathological T category. Remember that the clinical T category information has to be used. You have to include this when you're assigning the pathological T category, except of course when it's been disproven by the resection. And important when assigning the T category to read all of the category criteria to choose the appropriate one, and always assign the subcategory if possible. Be specific. And as I mentioned earlier, keep reading through them until you hit that point of that's too much, because too often people stop at when they find the tumor size, but don't go on to see other structures that have been invaded, which could be in a higher T category. And it's important to understand the anatomical location of the tumor and the spread. Pleural-based is not involving the pleura. It is the location of the main bronchus, the lobar bronchus, and the hilum is also playing a very important role. So you need to know where those structures are in regards to the tumor that is being described. And there's many clarifications in the chapter that can really help the registrars. There's discussion of direct invasion into adjacent ipsilateral lobe not being a separate nodule. Vocal cord paralysis is described, as well as Pancoast tumors and how that affects the staging. The clinical N category, mass, adenopathy, and enlargement are not always nodal involvement. You have to be very careful and not use those terms alone as being indicative of nodal involvement. That was true 30 to 40 years ago for chest x-rays. They were not very sensitive, and a tumor had to be extremely large with a large mediastinal or hilar nodal mass in order to be seen on the x-ray. That is not true for CT, PET, or MRI. That imaging is very sensitive, and rarely is that enlarged node information being seen on the imaging isn't malignant. Most often, it is an inflammatory process or a reactive process. So be very careful. Don't use those words and assume it means nodal involvement. Remember, registrars cannot use old rules that we've used to and we've memorized and passed on to other registrars and apply them to modern medicine. Rules must change and keep pace with the changes in medicine. And it was actually a physician who was at an NCRA conference in 2013 getting ready to do a lecture coming up next when he was hearing a current lecture going on discussing these registry rules about mass and adenopathy and enlargement, always meaning nodal involvement. And he met with us later and explained the differences, what was true in chest x-rays and what is now true in modern imaging. So it's important for registrars to choose accurate information and staging over historic compatibility when we're talking about AJCC staging. The clinical N category. The imaging evaluation of nodes is very critical. You need to look at the size that's involved and also the SUV, the standardized uptake value on a PET. That will help guide the physicians into deciding whether or not those lymph nodes are involved. Registrars must use critical thinking with imaging reports. The radiologist will comment and have some interpretation, but you also need to look at the managing physician comments in the progress notes. The managing physician will take everything into consideration, not just that one imaging report. So while the radiologist may think that one imaging report looks like the nodes are involved, there could be additional imaging that disproves that. So that's why you need to look at everything and really look at how the managing physician is putting all of this information together and looking at the whole picture in order to make some decisions. Now for size and SUV, I've asked physicians and they really cannot provide an absolute criteria and cut points for registrars. You must take into consideration other statements being made about the imaging and other diagnostic workup. For example, a large size may be due to inflammation and not tumor. So that's why it's important to really look for the managing physician's decisions on whether or not these nodes are involved. The pathological N category. Remember to include nodal imaging or nodes seen by the surgeon. As long as one node has been microscopically examined, that now meets the PN criteria. And so the PN now includes all clinically involved and microscopically proven nodes, unless some specific node involvement has been disproven by those biopsies or the node dissection. So remember, you need to put everything together. Another caution, remember to include lymph nodes biopsied during the diagnostic workup. So if you had some nodes biopsied during that diagnostic workup, you need to add them to the lymph nodes that were resected. Don't forget to put together that whole picture and not just look at the path report from the surgical resection. Clinical M and pathological M categories. It's important to assign the subcategories. Even though the stage group is not affected by M1A and M1B, it's still important to have that M1A, M1B, and M1C data. It could lead to different stage groups in the future. We just need enough data in order to show that it has a difference on the outcomes and the survival of the patient. And in assigning the correct CM or PM, remember it is based on the method of assessment, not the stage classification. M1A microscopically proven and M1B on imaging would be PM1B. Not all METs must be microscopically proven to assign the PM category. And no METs microscopically proven is CM for the pathological M category. Now, some special situations with their category. There's a lot of information in the AJCC chapter regarding this. Chest wall invasion is T3, not M1B. And remember, the chest wall includes ribs, sternum, skeletal muscle, and the diaphragm. Pancoast tumors may be either T3 or T4. An invasion into mediastinal fat is T4. Discontinuous tumor nodules in ipsilateral-parietal or visceral pleura, that's M1A. Outside of the parietal pleura in the chest wall or the diaphragm, it's M1B or M1C. So there's a lot of help in the chapter for these different situations, so be sure and look for that. Now let's talk about stage classification, diagnostic workup, and treatment. Clinical staging. Many procedures may be used for staging, such as bronchoscopy, thoracoscopy, mediastinotomy, exploratory thoracotomy. Not all lesions will be biopsied, and it sometimes helps to look at the NCCN guidelines to understand what they're looking for and what they're biopsying and some of the guidelines to help registrars understand. Now, for pathological staging, you need a resection of the primary tumor. Usually there's a nodal resection with it, but you don't have to have that. In some cases, you can have a biopsy of the highest T and also a biopsy of the highest N, and that is in the general rules in Chapter 1, but you have to have biopsies of both the highest T and the highest N in order to use that rule to assign pathological staging. Now, the histologies that are staged in the chapter include non-small cell, small cell, and carcinoid. Do not use limited and extensive for small cells. Some physicians still tend to do that, but you need to remind them that everybody needs to use the AJCC T and an M for all of these histologies in order to provide useful data for analysis in order to help assess patient care and outcomes. Now, looking at the treatment may help the registrar understand the physician stage. For example, when you're looking at treatment guidelines, positive mediastinal nodes aren't eligible for surgical resection. So if you have that and the patient's going to surgery, I would question whether or not those nodes are really positive. And it's important to review treatment guidelines that can really give registrars a lot of help. These guidelines can be found in NCCN, and there's also additional guidelines available through ASCO. The criteria for clinical classification, also called pre-treatment staging. Patient is undergoing a diagnostic workup, which can include physical exam for lung function and potential supraclavicular nodes, history for risk factors, imaging of the lung and the regional nodes, sputum cytology, bronchoscopy with biopsy and transbronchial needle aspiration, imaging-guided needle biopsies or FNA, thoracentesis, mediastinoscopy, video-assisted thoracic surgery, VATS, and open surgical biopsy, endobronchial or endoscopic ultrasound-guided biopsy, navigational bronchoscopy. And remember, biopsies add time and risk, and they're not always needed for the treatment decisions. So don't negate something just because the biopsy wasn't done. And it's really rare to have incidental findings of lung cancer on a surgical resection. So we don't usually see that in clinical staging. Now, diagnostic versus treatment. Diagnostic procedures include a sampling of the lung tumor. It's not intended to remove the entire tumor. It's not known if the entire tumor is removed at this point. And don't be confused by surgical procedures, such as VATS. The surgical treatment of the primary site includes a resection of the lung tumor. Extent of the resection would depend on the clinical stage. The margin status does not change whether or not this is treatment. And if a nodal dissection is not done, it's still considered treatment. Treatment satisfying the stage classification. For pathological staging, it would be a resection of the lung tumor. You most often have a nodal dissection. Sometimes it's a sampling from multiple stations as described in the chapter, but it's not required to qualify for staging. And the contraindication for surgery is usually positive mediastinal nodes. If there's a surgical resection, they must have a formal mediastinal node dissection if they go on to do this, but it's not common. For post-neoadjuvant therapy staging, you must meet standard guidelines such as NCCN or ASCO. The indications for neoadjuvant are commonly greater than or equal to 4 centimeter or node positive, along with no contraindications. And usually definitive concurrent chemoradiation is the most common type of neoadjuvant therapy given. Information and questions on AJCC staging. Timing is Everything is a useful graphic that can be downloaded from free from the AJCC website. You can see that the arrows define the time frame and the square boxes define the criteria. It really gives you a visual interpretation of the different types of staging and what is included. The AJCC website can be found at cancerstaging.org. It includes general information with an overview, version 9, all of the cancer staging systems, and there's a free download of the AJCC 8th edition, Chapter 1, Principles of Cancer Staging. There's cancer staging education and frequently asked questions. The Cancer Forum is a useful resource. Be sure and look to see if your question has already been asked and answered before posting a new one. That's why we say it provides information for everyone, because one person's question may help a lot of people. We also look at the questions that are posted for educational purposes to decide where and what types of information is needed. This has been developed through generous support from the American Cancer Society, and we thank them. And I'm Donna Gress, and I thank you for your attention today.